All right, here we go. Got a good case here. Pretty straightforward though. So a 64-year-old gentleman, he reports that he had cataract surgery in his right eye with a USF along the line about 3 weeks ago. He says his vision out of that right eye has now been very grainy and blurry since that time. And more recently, he's had cataract surgery in the left eye this past week. He says his vision is clear out of the left eye. But he is seeing this vertical black line in his peripheral vision that was not present before the surgery. So of note, he was set for monovision, right eye is for distance, left eye for near reading, and he's referred to your retina practice for possible retinal surgery. That's all you're given.
Yeah.
Past medical history of high blood pressure. He's on a statin, aspirin, multivitamin, and Bicepa. And vision in the right eye is 20/40, and pinhole has no improvement. And then left eye is 21/25, but pinholes to 20/25. And again, that left eye is set for near, right eye for distance.
Have you guys, speaking of diabetics and medications, have you guys been getting any cases canceled for Ozempic?
Oh, canceled.
The
Yeah.
VA specifically asked them about it and they
Right.
stop it a week in advance.
Yeah, it's driving me nuts, but all the GLP-1s for non-diabetics, it's gotta be 2 weeks, for diabetics, gotta be a week. You can beg them, if it's a retinal detachment or something, they'll tube the patient. But anesthesia is like canceling like left and right. For Ozempic.
For math cases or for all?
Yeah, for Matt, they don't like the anesthesia because the stomach emptying. They feel like you're not emptying right, so they want to be off the meds. So I didn't realize it's driving me crazy.
And you said for non-diabetics?
Non-diabetic, they're like 2 weeks off, for diabetics, they're like off for a week, and that's our guidelines, unless you're gonna do an ET tube. So I've had probably 4 or 5 cases.
Did they just make this up?
Probably, but in your setting, but in the, like for elective macular pucker, macular, like the regular elective surgeries, it's been a pain in the neck.
Oh,
And there's a bunch of other ones, there's a bunch of non-Ozempic GLP, there's a bunch of different names.
Do you do a lot of cases under this math?
Yeah, I do mostly that,
Oh, really?
yeah,
Macular.
yeah, I do buckles just general, but otherwise.
Oh, wow.
Yeah. You guys in training, if I had a trainee, I would do general.
Yeah.
I was sitting there going, oh my God, it's like. Yeah.
Yeah.
Yeah, it's totally rational. All right, go ahead.
All right, so moving on. There's the first photo, let you take over.
This is infrared of the right eye. Media is clear, vessels look okay. I'm kind of drawn to the macula where I see kind of all these striations, it looks like.
Exactly, so, and yeah, I think with IR, it's like hyperreflective, but exactly, there's like these linear striations kind of emanating and just kind of.
And then maybe one little hyporeflective area, kind of superior right there. Yeah, where your mouse is.
Yep. That's real or?
It might be real.
It
Might be an
can't really
artifact.
tell. Yeah, but it is present in other photos. So moving on.
So this is an OCT of the right eye. Looking at it superiorly, it looks like there's a hyperreflectivity, possibly an epiretinal membrane there, and it's kind of distorting the foveal contour as well. And then maybe some of like hyperreflective material within the inner retinal layers as well.
Yep. So yeah, definitely hyper-reflective on the ILM and the inner retina. And then a definitely distorted foveal contour, maybe some like retinal.
Those are funny little things. I see those sometimes and sometimes I don't see them and I'm not sure that they're important. I'll try to find out, because I do look at those things sometimes and they shouldn't really be there. There's no vessels in that layer. So yeah, I think it just has to do with the imaging and when the macula is not flat. I'm not positive.
And then another OCT is this eye.
Code gold, adult inpatient, A2. Code gold, adult inpatient, 8 alpha 2.
So in this thing, still just kind of reiterating that hyperreflectivity along the ILM, again, possibly epiretinal membrane and distortion there of the foveal contour.
Yep, agree. And then just pretty good preservation of the ellipsoid photoreceptive layer, but exactly like you said. And then these are just little acoustic shadows from blood vessels.
This is same eye still for.
Yeah, it's the same eye. I think this is a vertical cut. So patient seen several months later and vision spontaneously improves to 2016 in that right eye. Any comments on this photo?
So color fundus photo here of the right eye. Again, you can see those striations that we saw earlier in the IR, and that hyporeflective area we saw a little bit earlier kind of looks like maybe a little bit, I don't know if that's like artifact for reflection or if that's just like a little bit of a defect that you can see through the choroid through there.
And one little teaching point is the striations are actually, so here's the membrane here and over here. And the striations are where the membrane's not usually. So what's happening is the membrane's contracting. I always show people with my pants, I can show people in the room. Yeah, I bunch up my pants like that, and I go like, that's the retina, the pucker's here, and the striations radiate out from it. So if you're operating, you gotta be careful you're not peeling the striations. Perfect.
And then just another photo, IR, we've kind of seen it already. But yeah, there's that little spot again. It's really not related to this case at all, but
I think it's an artifact. The computers, the images will throw a central artifact. There's a way to get rid of it if you wiggle the camera while you're shooting.
would you call it artifact if it's present in multiple series of photos taken over different
I
days?
don't know. Is it the same though? Let me see that one.
That's the
That's the
initial,
initial one.
and then here's when there's spontaneous
Okay.
resolution.
And then what's the
months
next
later.
one? No, maybe it's not an artifact.
But we don't pick it up with the OCT, but we don't have that cross
You
section.
don't have that cut.
Yeah.
It might be a little area of atrophy.
All right, so key findings here.
Oh, go back to that last picture.
Yeah, this,
Oh, yeah, sorry.
That's kind of the whole thing.
So that's the initial OCT, and here's the OCT from several months later. Just any obvious findings, comments?
It just looks like now the foveal contour is kind of better improved than it was previously.
Yeah, absolutely. And yeah, really picking up that same cross section. And just like you said, good foveal contour now.
And from the grading lecture last month, the top one would be a grade 2 and the bottom would be a grade 1. If you're grading your epiretinal membrane.
What was the vision on the top one again?
2025, wasn't it?
Oh, okay. It was.
Do you remember the vision?
In the top picture,
I
what
think it
was
was
that?
2040,
Oh, was it 20?
2040 with no pinhole improvement. And
Oh,
then,
yeah.
yeah, then it was.
Cause the ELM is so good.
Yeah. All right, so this was a short case, 64-year-old guy with grainy blurry vision out of the right eye. You see the cellophane-like membrane over the macula with surface wrinkling, like you commented on. Initial OCT shows a hyperreflective membrane on the inner retina, ILM, with loss of the foveal contour, some irregularities in the inner retinal surface with increased retinal thickening. What's our differential?
Yeah, ERM's kind of at the top of the differential, maybe with some VMT. You could also consider like another type of membrane, like in diabetic retinopathy or something like that, but leaning more towards just the ERM.
Yeah, absolutely. And so because he just had recent cataract surgery, you think about like a pseudophakic CME with just increased thickening of the retina, maybe some cystic edema, maybe some vitreomacular traction, but we didn't really see that with OCT, any vitreous traction, macular pseudohole, and then maybe like proliferative DVR. But yeah, it's definitely macular pucker, ERM. And then for the left eye, just remember, like the patient had this like weird shadow in their vision. This is something I've come across a lot now in post-op patients, and this is really just a negative disc photopsia where they're like just catching like the edge of the optic with their new lens. And if you just like have them hold their hands like to their temporal aspect of their eye, like that will be eliminated. And it's like a good sure way of like reassuring yourself that it's not like an acute PVD or a start of a detachment. So that's pretty common that you'll find with post-op cataract patients. And that tends to get better with time because patients neuroadapt and that kind of.
And they're not, it's not that the optic's exposed. It's a weird optical phenomenon.
Right.
So it's something about the light reflecting off the retina, hitting the optic.
Mhm.
What is the type of lens that makes them have negative disc photopsias again? I just saw this question and I already forgot the answer.
Is there a type?
There's a couple criteria. It's like whether it's round or square.
Yeah.
Do you remember which?
No.
I will look it up. I just got it.
But there's like a couple of it.
Okay.
All right, so yeah, this patient had macular pucker with a spontaneous peel or spontaneous resolution of the macular pucker. The BCSC says like all these terms are essentially synonymous, but I kind of disagree. I think it'd be inappropriate to call it macular pucker if there wasn't like a puckering of the macula, like distortion of the anatomy. But it's also known as surface wrinkling retinopathy, cellophane maculopathy, epimacular membrane. So what is an ERM? It's avascular fibrocellular tissue that proliferates on and adheres to the internal limiting membrane of the retina. It's composed of various cell types, most notably retinal glial cells and RPE cells, as well as astrocytes, fibrocytes, myofibrocytes, and macrophages. Its prevalence in the US, it occurs in like 2% of people older than 50 and over 20% in patients over 75 years old. So direct correlation with age, but basically equal in men and women. Bilaterality occurs in approximately 10 to 20% of cases, and most often it's asymmetric, depending on like when a PVD occurs in a patient.
And it's thought that they do form. It's an interesting thing, the idea that they form on the ILM,
Mhm.
because there's some thought that it's become common, I think, to peel the ILM
Mhm.
in a lot of surgeries to try to prevent macular pucker formation.
No, like while you're already in there.
Yeah, while you're in there.
Huh.
I don't do it on RDs. I mean, yeah, I've seen people do it. It's kind of like, oh, but for macular puckers, do you do it on your puckers? Go
Yeah.
back and,
Or ERM, yes.
Yeah.
To the ILM also.
yeah, while you're there. And I think it does reduce. I don't know that it's zero though. I think I have seen them come back, but it's supposed to drop the recurrence rate.
So the majority of ERMs are idiopathic, meaning there's no known underlying cause, but it is agreed upon that essentially a PVD is a necessary prerequisite for an ERM to form. And that's why it occurs in patients who are older, who have had PVDs. There's several theories on how this occurs, but again, all are related to that initial event of a PVD. So the first theory is that there's microglia cells that migrate to the surface when there's these little microbreaks in the ILM that migrate there and differentiate into fibroglial cells. Number two is it's thought that there's like adherent vitreous on the surface and those cells will differentiate into myofibroblasts. And then number three is that there's an avulsion of the ILM and that will cause this like cytokine signaling cascade that will upregulate signals and cells to form this ERM. Secondary ERMs are associated with an underlying retinal disease. So that includes diabetic retinopathy, vein occlusions, various inflammatory diseases in the posterior segment, as well as trauma and previous surgery and tumors. If you actually look at the cell types of these ERMs, there's subtle differences, so not so much microglial cells, but more RPE cells, macrophages, T and B cells, just indicative of that underlying inflammatory process. So signs and symptoms, obviously you're looking for this like cellophane type membrane in the macula. And as it progresses, it can become more opaque and fibrotic. And you'll look for the stria, like Dr. Cohen was pointing out with his pants. And another good clue is to look at the retinal vessels. So you can have either increased tortuosity or straightening of the vessels. And I think I've noticed more so straightening of some of those blood vessels, just based on the vector forces pulling some of those macular retinal vessels. In terms of symptoms, patients will have metamorphopsia, blurred vision, they can have monocular diplopia, and even micropsia. But vast majority of patients will be mostly asymptomatic and really not even appreciate it too much. So diagnosis can be made at the slit lamp with a good history, but obviously definitive diagnosis is made with OCT, with all the findings that we saw in this case. FA can be used as a supplement, especially when it's suspected that there's like a secondary underlying cause. And with FA, you might see staining of the optic nerve head as well as capillary leakage in the central macula. Again, just from those vector forces pulling on those very fragile blood vessels. There is a grading system that I found, but I don't really think it's used too much in the clinical setting, but obviously it can be a useful prognostic kind of technique and a good way to guide your management and making that decision to do surgery. So grade 1 would just be a simple ERM where there's really not a lot of contractile forces and there's good preservation of the fovea. Grade 2 and 3 is just kind of a progression where you're losing some of that inner retinal anatomy and architecture, but there's still good preservation of the ellipsoid zone. And then a grade 4 advanced ERM, you have a total loss of that retinal architecture, most notably the ellipsoid zone. And so that's when it's going to become visually significant for a patient. Do you use this grading system?
I do.
Yeah.
I put it in my charts. I like it.
So when an ERM is asymptomatic and a patient's vision is good, intervention is not indicated. But obviously these patients need to be monitored closely, and that varies from provider to provider, whether it's every 6 months or every year. And you can kind of extend that depending on how stable it is. There was one study I found based out of Australia called the Blue Mountain Study. It involved 3,500 patients and monitored them over a 5-year period. It showed that 20% of ERMs progressed, about 26% regressed, and then 40% remained the same. So the far majority of these ERMs will either stay the same or regress. But it's just kind of useful to have that as a reference when talking with your patients. And then obviously for monitoring, you're mostly looking at the ellipsoid zone. That will correlate to their vision.
That's not even
I
close
think
to 100%.
Some of them had surgery. I've seen studies, I was thinking the same exact thing. I think when a lot of those studies, then there's probably the rest of them are surgical. I would guess, and they take them out of the study. Because I done exactly the same thing.
And let's see. So when an ERM is symptomatic, obviously you want to be able to offer them surgery. The threshold to take a patient to surgery varies from surgeon to surgeon. I know when I was asking some of the USF and VA attendings, they told me something around 2060, and obviously it's affecting aspects of their daily living. Mainstay of treatment is parsplantar vitrectomy with a membrane peel, plus or minus an ILM peel. So like Dr. Cohen was referencing, not everyone does it, but it's kind of, it seems to be favored by most retina specialists. There was one study looking at surgical outcomes with a mean preoperative vision of 2110 and mean postoperative vision of 2055 after like a 3 to 6 month period. So for most of these patients, there is a pretty good improvement within that first year, and even more improvement down the road within 1 to 2 years. And reoccurrence is about 1% of these patients who have surgery. And then Dr. Cohen did
Gold,
provide this video before.
adult,
An
ED,
article, so I added it.
2K5, adult, ED, 2 kilo 5.
What is that?
Oh, it's a contact lens. I like peeling through a contact lens. Some of my partners use the reset. Do you reset it?
I
We all
always
use
use the contact lens.
Okay, yeah.
And then here, I
okay.
tried the contact lens here and it wasn't the same that I was used to, so I used the reset.
Yeah, the reset's pretty
So,
good.
yeah.
I like the contact. So you just grab it and peel it. Nowadays, I mostly stain. The stain's interesting. The stains stain the ILM. And the ILM's under the membrane, so when you peel it up, yeah, these.
Yeah, so this is peeling of the membrane, and then you're gonna stain it with the.
Oh, and then
vision
peel
wheel,
again,
And then peel the ILM.
which may not have been necessary, because it wasn't in the macula, but I figured. In there.
Oh my
Yeah,
god,
it's
that might be
basically
the greatest thing I've ever
With
seen.
that very
Yeah, I like the
distinct
colors. The
side
colors are
effects.
so nice.
Arachnophobia.
Feels like you're cheating. It's in these forceps. Realize our forceps used to be 28. These are 25. It was a bear. It was like grabbing with a pair of pliers.
Yeah,
You used to have to elevate it with the blade.
but you do those flat, right? The
What's
island
that?
flat,
For holes.
over holes
Yeah, for
only, not
holes
for
only.
this way.
All, every case.
Can you?
For holes. If I, no, for
Color find this way.
2 holes, I don't peel ILM. I'm one of the only people I know that doesn't.
Or,
So if they're small holes, I don't even peel the ILM.
Oh,
I
so
just
just-
gas them.
oh,
And
okay.
if it's a 3 or 4, if I'm peeling the ILM, usually if I can, I just leave it.
Okay.
Sometimes it sucks. A lot of times.
That's the way.
It just gets gone before you know it.
Why does the center of the macula look like that?
Funny looking.
Yeah.
That's
Funny looking
probably, that might be an absence. This was the post picture, right?
Yeah.
Yeah, so this was, I think that's where the membrane's not there anymore, kind of retracted. So it's sort of pulled away,
Yeah, it's pulled away from the fovea.
right? So the fovea looks better.
Why the vision's.
So that would be an example of a pseudo, it's a bad example of a pseudo hole. Where you look in and it looks like a hole, but it's just a hole in the eye, in the ERM.
I figure out why it looks like that.
Oh, because you're thinking you're multicolor thing. All right, any other questions on that one? Very good, Kevin, thank you. So the.
Hey, Dr. Cohen,
Yeah,
I had a case. Can I share my screen?
yes, let me stop myself.
Mark.
Oh, is this